Okay, so I want to, as we get started today, I don't know if everybody's aware, but if you're not, we did want to make the announcement and give everybody the opportunity to check out. We have a new department podcast series. It's called the Mentors Podcast. It was created by Dr. Christian Fernandez Falcon. And so we just want to invite you to check that out. It's on our home page for the department, and I'm going to actually post that link to the podcast series in our chat box here in just a moment. But we just wanted to make sure everybody knew about that's something new that we are sharing with y'all on our homepage. So next slide. We want to welcome everyone to the Family Medicine Grand Rounds for today, June 30th. Our event code for today is 181047. You can contact the CME office if you have any questions, but I will also be posting again the link for those of you who are registering, and otherwise you can do that by phone also, but please make sure that you do register if you're interested by midnight tonight. Next slide. So we want to thank everybody as we get started here for muting your microphone and also being attentive to our presenter. This is going to be an interactive session, so please, as much as possible, try to engage in the sessions. We're going to be doing some breakout rooms, but also I will be giving you the evaluation link towards the end of the session if you can help us by filling out the evaluation for our presenter. And so this is the South Texas Family Medicine Grand Rounds. We are partnered with the South Central Area AHEG, and our department's mission statement is listed there for you. Next slide. For those who are interested in their CME, you are able to download your transcript by going to the CME office website. It's listed there. You should be able to log on and print that out. But if you are having issues or you do have questions, please feel free to contact me. And if I'm not able to help you, I can also get you in touch with the CME office. Next slide. Also, some of you may be members of AAFP and are looking for credit through that organization. So if you do need to, please make sure you claim credit through them. But if you have issues or questions, please let me know as well. Next slide. So Dr. Andry has no relevant financial interest with commercial interest to disclose. He is our presenter for today, and he's going to present to us strategies to prevent and address common clinical teaching challenges. So I'll let him take it from here.
All right, well, thank you, Nicole, and thank you all for joining me this afternoon. More than that, thank you for what you do to teach the students. You've made a huge impact on their lives, whether you recognize it or not. And so today we'll be talking about strategies to make your teaching more enjoyable, more effective, and more efficient. So the objectives of this session are as follows. Number one, identify common challenges to teaching medical students in the outpatient setting. We're all very familiar with the challenges, but just so we can kind of empathize together, we'll review those. Number two, explain the 1-minute preceptor 5 microskills method of teaching and providing feedback to medical students. So many of you are probably familiar with this method. If you are, fantastic. This should serve as a great review. If you're not, this should hopefully give you some tools to use in your clinical teaching moving forward. And then number three, discuss tips to effectively implement this method of teaching and providing feedback. As Nicole mentioned, this is going to be an interactive session. So I'd like to start with just some reflections from the current clinical teachers, whether you're a faculty or resident. If anyone would like to share what their favorite memory about clinical teaching this past year has been, I'd love to hear it. I'm sure we'd all love to hear it. Anybody want to volunteer here? Favorite teaching moment from the past year?
Well, I'm going to volunteer. It's when we went back in person to teaching as opposed to the long period we had when we didn't have any direct interactions. I think the current set of students has had some decrement in their educational experience based on that. And of course, we have our outstanding interns starting tomorrow. And they've had some of their experiences watered down by this series of events. So I guess that's my favorite thing.
I second you there, Dr. Nato. You know, it was, you know, it felt like part of us was missing when we weren't able to be there in person. You know, I'm sure the students felt the same way. So I think that that's certainly a great highlight, great memory from the past year. Any rising PGY3s with us, or anyone else want to share another teaching moment from the past year, maybe before we get into this one?
So I just share one more thing, and that was I greatly appreciate the specific feedback that your office has shared with us as faculty and with the residents. And I think it was a great addition this year that we were able to recognize a specific graduating resident for outstanding outpatient teaching. So thank you for that.
Yes, sir. We, you know, we try to provide that regular feedback for resident teaching skills. We'll be hosting some sessions throughout the coming year for residents as teachers to keep everyone engaged, up to speed on things. And you're right, there's so many great teachers amongst the group. And it was very exciting to be able to award Dr. Ibarra Becerra with that honor this past year as the resident teacher of the year. She was fantastic. We'll certainly miss her. For the rising PGY3s, you've had a chance to do some clinical teaching as second year residents. Anything you want to try to improve on in regards to your teaching in the coming year? Would anyone like to share there? Have any rising PGY3s?
Yeah, Dr. Andrew, I think it would be nice to, I guess, work on trying to get the students their experience that they're here to learn in addition to getting through our patient, because we're going to have more patients as a third year. So I want their experience to be enjoyable as well and not feel rushed.
Fantastic. I think that's certainly a great area to work on, and I hope that you know, this session today may provide you with some ideas and tools and skills to use in the coming year. That's something great to work on. Any rising PGY2s out there? So what concerns do you have about becoming a clinical teacher?
This isn't like a memory, but today I had a med student for the first time in a really long time, and I felt very rusty and guiding. And so I definitely am all ears about how to manage and make it the best of my time and their time.
Fair enough, Dr. Walker. You know, it's like anything else. It takes practice, and so we'll practice some skills this afternoon, and I think hopefully by tomorrow morning or the next time you have a student again, you'll feel more comfortable. But it's like riding a bike. So
teaching is not intuitive, and so I think some people come to it more naturally, but there are some things. So this is one of the sessions that we do to try to give you some specific teaching strategies and skills to improve yourself as a teacher, both for faculty and residents. Additionally, the med school has some modules that they have residents do on a regular basis to help with that as well. So part of the formal education.
Yes, sir. All right, so just to get started, there's obviously various challenges to teaching in the clinic. The first one I think is pretty obvious: time constraints. Don't we wish we all had more time? You know, clinics are fast paced, 15 minutes for this, 30 minutes for that. It's rapidly moving. That also includes managing your inbox, making sure you're filling those medications. in a timely fashion, responding to calls, reviewing results. You know, I wish we had more time. So time is certainly a challenge. The environment, it's chaos sometimes. So there's constant changes in primary care and family medicine, our patient mix, the complexity of our patients. That's certainly a challenge. Look no further than the article cited here from our very own Dr. Catterndall. So the complexity of what we deal with is very real. As teachers, we're still learners ourselves. So I hate to break it to you, the residents that are out there, but we don't have all the answers for everything. If you've worked with me, you've probably seen that I certainly don't have all the answers for everything. And so there's learning that happens while we're teaching as well. And then certainly medical student attributes that, you know, that can be a positive or a negative there. They have different, certainly different desires and readiness for our autonomy, depending on where you're catching them in the academic year. You know, our lack of continuity with those students certainly poses a challenge. And medical students, they want feedback, they want to improve. And, you know, sometimes they're not sure how they're performing, and that may cause some disconnect here and there. So we'll talk about ways to help with that. So here's scenario one for you. I'll read it to you, and then we'll talk about how we're going to break off and do things here. The student you're working with has spent several more minutes than anticipated in the room with the patient. You thought this would be a quick follow-up. However, as the student is presenting the case, it is clear they performed a history and exam beyond what was needed for the visit. You're behind schedule and can sense yourself becoming frustrated. Has anyone been in this situation? I'm not going to say before, maybe this week. So this is a common occurrence. We're all primary care family docs here, so we're all in tune with the various levels of prevention. Prevention is something very important to us, and you'll recall the various levels of prevention from primary to secondary to tertiary. You know, certainly catching things upstream, very important. But depending on the situation, you may be doing some damage control. So what I'd like for you to do for this first scenario, Nicole's going to break you guys off into triads. And I want you to think about these various questions. What could have been done to prevent the situation? What can you do in the moment if you recognize a delay? And what can you do after the fact to prevent a future recurrence? So we'll give you 5 minutes to break into groups to talk about these three aspects, and then we'll come back together and share some best practices. So Nicole, go ahead and work your magic here.
Okay, give me just 1 second. I had someone leave, so I'm trying to make these even again here. Give me 1 second. All right, I'm gonna send them out. don't know who's trying to speak. I don't know if that's Dr. Catterdahl, but I can't pick up on it.
How much time do we have left, Nicole?
Probably about a minute or so. About a
Okay.
minute. I had I was just gonna ask you, when you're ready, just let me know and I'll close the rooms. I'm gonna send a message for those who feel that they're finished to just come back to the main room.
Okay.
I don't know if that's you, Dr. Catterdahl, but your microphone isn't working. I'm gonna go ahead and close the rooms, Dr. Andry.
Okay. All right. Well, it looks like most folks are back. I hope you enjoyed going through that activity. At this point, I'd love to hear from you regarding this, the first question. So what could you have done to prevent the situation described in scenario 1? Anyone have a best practice to share regarding this?
I think we discussed like maybe having a student shadow us on the first patient initially to see how we do
It was a
things.
very good interview, you know.
Especially if it's their first, first day or first couple of days in the rotation, to shadow us for the first patient and see, and then set expectations early on and let them know like how many patients we're gonna get them to see for this half day instead of like the whole panel, maybe 2 or 3.
Okay, I like those strategies. So you're defining those expectations from the start of the rotation, from that first time that they're with you. You're letting them shadow you perhaps for a few patients to become oriented to the clinic itself, your preferences, your style. I think those are fantastic strategies. Did any groups have any others? Any other best practices?
We talked about pre-screening the charts to make sure you don't send a patient into, a very difficult situation. And then we also talked about setting time restraints. So you can go see Mrs. So-and-so, I'll give you about 10 minutes. And so they have that in their mind that, okay, I don't have all afternoon to talk to this patient.
Very good. I love those strategies. So you're strategically assigning those patients based on your understanding of who that patient is, whether or not it may be a good fit for the student or not. And it sounds like you're also prepping that student from the beginning, again, regarding your expectations, and you're setting a time limit and letting that student know, hey, in 10 minutes, if you're still in the room, here's what's going to happen, so that they're not caught off guard later when you knock on the door and say, hey, I'm going to join you, or let's come talk about this, or whatever that may be. Great strategy. What else?
Going off of that, we were saying how kind of to relay expectations with the student. If the student didn't understand that it was a follow-up visit, maybe clarify the difference between a brand new visit or a full history and physical, as opposed to just a follow-up that has more of a focused exam, and lay those expectations out.
Fantastic. Visits differ by reason for the visit. So I agree that's a great way to prep that student. All right, well, let me share a few things here.
Neiman, I just wanted to add, I think a good place to start is with starting with your expectations, right? So your expectations for us are that the student doesn't have to see the whole panel. They see 2 or 3 patients and they write a note. And so that doesn't necessarily mean that by 1:05, the student needs to be seeing a patient. So that was our thought.
Precisely. So there's expectations and guidance that we give you from the clerkship, from the school. And then there's your personal expectations, and both are important. And Dr. Nato's exactly right. We don't encourage the student to see every patient in the panel. Think back to when you were an intern. How many patients were you assigned per session? It wasn't 10. That number was probably close to 3 or 4. And so how can we expect a brand new, fresh third-year student to see more patients than an intern would? And we don't. And there's certain things that student can be doing to still actively engage in learning in the clinic without having to follow you for every patient or to see every patient necessarily. So yes, defining expectations from day one, super important. Creating a positive learning environment, also very important. That'll help build that student's trust. It will, it'll make them more likely to ask you questions. How may you create a positive learning environment? What do you do there? How do you do it? Or what have some of your good teachers done?
I think the teachers that openly, like you said earlier, can openly say, like, I don't know everything, I'm learning with you. I think that was always reassuring.
Fantastic. That's a great point. Even things as basic as using the student's name, taking the time to learn their name, calling them by their name, not, hey, medical student or whatever. Learning their name's important. Talking about their learning goals. Showing enthusiasm for teaching, for seeing patients, etc. You're under the microscope to them, and they're really taking in your every move, every word. So you say as much by what you do and it's as powerful as what you're actually saying. So the nonverbal stuff counts too. Make that student a part of the team. They want to be actively involved. So, it certainly shouldn't just be a shadowing experience for them. And so by doing this, they'll pick up things quickly. Orienting the student. So they get a site orientation. They get oriented to your workflow, to your panel, letting them know the types of patients, the types of visits, etc. So investing some time up front should definitely pay off later. You guys mentioned this one already, strategically assigning patients. And our strong recommendation here is 2, maximum 3 per half day. And that's for the reasons we discussed. These are third-year students at the beginning of their training. The other thing you guys mentioned, taking that time to briefly huddle with that student prior to the visit, to review your expectations, provide them that patient context if known. That's going to certainly probably help you save time later.
Neiman, you got one more. Before you leave the slide, I just want to give an example about making the student part of the team. One thing that many of our residents do extremely well is having them present a patient or 2 to the faculty. And one thing you can do to make it a good experience for them is coach them up a little bit so that they can make a good impression, right? Allow the student to shine, help the student to shine. I think those are things that you can really do to enhance the day.
Great points, Dr. Nato. I know you love it when the students, are presenting to you, even though you may be precepting several residents. You're right, it certainly does get them involved. Great strategy.
Dr. Andry, I wonder that you were saying about the number of patients per half day.
Yes.
I wonder if that's maybe depending on where the student is in terms of their year, those who are third years who are almost finished, if they only do 2 patients, they get bored. So I think that, just being sensitive to the burden, but also to the opportunity.
Sure.
Because if they're just get done and they're just kind of twiddling their fingers, we might want to pay attention to that.
Absolutely. Again, not to quote Dr. Catterall on all these important points, but let guidelines be guidelines here. And this is a general suggestion. Yes, you're going to have students that are more high performing. By all means, if it works for your panel, if it makes sense, if the student is very eager to see more and it's not going to throw you behind, have at it. That's they're there to learn. So I agree with that. It depends on the student, depends where they're at in the time of year. As we talked about, prepping that student regarding what intervention is going to happen if that visit becomes prolonged, also very important, so there's no surprises. Encouraging an open dialogue and trust, as we've talked about, also a key to success here. Okay, so now moving on to in the moment. So what can you do in that moment if you recognize that visit is becoming delayed or prolonged? What did you guys talk about here?
So we were saying that it's kind of hard to react in the moment, especially if you're starting to get flustered, but you can't change the past. You can only move forward. So it's important to pause and collect yourself and understand where the student is coming from, because maybe since it was a follow-up visit, you kind of go in with a bias as to what you're looking for, but maybe the medical student was able to unravel something new from the patient that is concerning and that you should address. So it's important to, in the moment, I guess, just pause and evaluate the situation.
Great point. That would go if you're getting frustrated or flustered in any type of situation. So taking that moment to gather yourself, without being on the other side of that exam room door, you don't exactly know what's going on or happening in there. I remember back as a resident, there was a patient who came in with diarrhea. And Dr. Sasha Lafredo was my preceptor that day. If you know Dr. Lafredo, she likes to get things done. She stays on top of you and make sure that you try to stick to schedule. I was in the room for a prolonged period of time. The student was in there with me. We were talking about differentials. It came up just in passing. Hey, could HIV be on the differential? Sure. Patient hears that, they start crying. And so in that situation, getting in and out was not, I think the final diagnosis was just viral gastroenteritis, but, being in there for the patient and giving them what they needed was important. And that takes time, sometimes, most of the time. So totally agree with you there. What other strategies did you guys come up with here?
I would advise self-reflection, right? You're behind, you could have managed it a little differently. So next time you can manage it differently because you've learned from this situation.
Fair enough. You'll get another shot at it, right? This won't be your last patient panel. This won't be your last teaching opportunity. So certainly learning from your mistakes, very important.
We talked about joining the student and not steamrolling them, but joining them and then continuing to incorporate them in the visit. But at that point, you can direct the visit. You can have the medical student summarize what you've heard. And like Dr. Palacios mentioned to us, like sometimes the patients like hearing that recap of what they've just told the student and occasionally can clarify on things. So as long as you don't barge in on them and take over the visit, I think going into the room and joining them is perfectly fine.
Totally agree. And you bring up a lot of great points here. There's a number of things, a number of interventions that you can do in the moment. to try to get things back on track, or at least prevent further delays. Entering the exam room, as you mentioned, great strategy. If you do it calmly. When you get in that room, yes, having the students stop, pause, present what they've found, completing the rest of the encounter together, that may be appropriate. Perhaps you may act as a fly on the wall in the room, act as a scribe, offer redirection if that's needed in any form. But yes, there's certainly things you can do in the moment to try to prevent that continued delay. Excusing the student would be certainly another option. If you are going to do this and pull that student from the room, prepping them before time that you'll be doing that would probably be best. We have gotten, I wouldn't say complaints, but some students who have described situations to us, maybe not in the Family Health Center downtown, but at one of our practices where the attending was somewhat abrupt, entered the room, pulled out the student, makes the student feel a little bit inadequate in front of the patient. And it just does not create that nice, warm, open learning environment that we're hoping for. So if you do something, try to do it calmly. Excuse the student if you need to from the encounter, and recalibrate things. So great strategies, fantastic. All right, let's hear about this one. So now after the fact, what would
So
you?
one last strategy for the last slide is talk to your preceptor. If you get way behind, they can actually do some things to help you manage the patient load, because we don't want the other patients to have to wait extremely long times just because you get behind, unless the patient specifically wants to wait for that.
Great strategy, Dr. Nato. It always helps to phone a friend. And yes, we're all here to help each other. So that's a great point. What would you guys recommend here? So what can you do after the fact to prevent a recurrence? What would you do?
Debrief with the student afterwards, go over what went right, what went wrong for both you and the student, and what you can learn from that.
Fantastic, fantastic. Any other strategies?
Attend to grand rounds to learn about education technique.
Dr. Nato has all the great answers here. So correcting mistakes gently, acknowledging that, yes, these are learners. Everyone makes errors. Errors are to be expected. We just need to learn from them. And being specific with that student, giving them that feedback on how to improve, very, very important. At the same time, you don't want to overwhelm that student. Hey, you need to work on this, that, and the other. One teaching point per patient seems to work pretty well. And if you can do this, perhaps in this situation, maybe it's something regarding agenda setting, tips for being problem focused, the value of providing longitudinal care to patients if that student was trying to address every single need during this visit. Also, perhaps talking about other members of the interprofessional team. I'm not sure whose mic that is, but it sounds like there may be a bird on the other
I
end.
think I don't know if Dr. Cadendall's isn't working, but I think every time he's talking, that's what's happening.
All right. Reviewing your expectations with the student to help them improve, that's certainly gonna pay dividends in the future. So fantastic. What I'd like to do for just a few minutes here is review the 5 Microskills model with you. This is also referred to as the 1-Minute Preceptor. It's been around for a while. You can see the citation there from all the way back in 1992. Not going to ask any of the interns if that was before or after they were born. So various studies have examined the application of this model, and the outcomes are very positive. So this should hopefully be a nice tool for you to use as you're teaching in the clinical setting. So these here listed are the 5 microskills. Number 1, get a commitment. Number 2, probe for supporting evidence. 3, teach a general rule. Number 4, reinforce what was done right. And 5, correct mistakes. And we'll talk about each of these briefly. So getting a commitment, what we're talking about here is having that student commit to a diagnosis, an evaluation, or therapeutic plan. So this is usually going to occur after that student presents the subjective and objective information and then kind of looks at you like a deer in the headlights and thinks, what next? And that's exactly when you can get them to commit to asking them something like, what do you think is going on with this patient? What's your assessment? What tests do you think are indicated? What would you like to accomplish this visit? And again, that's during the presentation is one point. You know, perhaps before the visit, after you guys review the chart together, that may be another nice point to get a commitment. What do you think you'd like to accomplish with the patient this visit? So this doesn't necessarily need to happen after the fact. Number 2, probe for supporting evidence. So by doing this, you're encouraging that student to give her or his rationale for the answer to the get a commitment question. So we're talking about the whys here. Why do you think X, Y, or Z? What led you to the diagnosis? Why did you suggest that medication instead of another? What factors did you consider when prescribing physical therapy? So these are all the why questions. Teach a general rule, pretty self-explanatory here. So this is where you're going to help fill in any knowledge gaps that student has based on the areas identified by her or his answers to the get a commitment and probe for supporting evidence questions. Here's a good example. First-line therapies for hypertension include ACE inhibitors, angiotensin receptor blockers, calcium channel blockers, and thiazides. However, your choice among them may depend on the patient's characteristics, such as comorbidities. So you're being specific here. You're teaching a general rule related to what the student has shared with you. You're not teaching 5 general rules or 10. 1. Keep it at 1. The student can digest that. They'll remember it better. The more you try to teach in one encounter, you're just prolonging things and putting yourself behind schedule even further as well. So 1 general rule per patient. Number 4, reinforce what was done right. Saying things like, hey, great job with that patient. Things like that sound nice, but they're not very helpful. They're not specific. When you are giving feedback to a student, whether that's positive or constructive, focus on a specific behavior and action, not on characteristics. For example, you consider the patient's lack of transportation and low income in selecting a home-based therapy exercise program instead of in-clinic physical therapy. This will likely result in better adherence to the therapeutic plan. So that would be a great example of reinforcing what was done right. And then number 5, correct mistakes. So, you know, using the word mistakes may not be, I like identify opportunities for improvement. That sounds a little better, a little bit more constructive. And again, right here, you're not saying things like, man, what were you thinking in there? That was a terrible encounter, or you're not using phrases like that. You're, again, focusing on specific behaviors and actions. I noticed you did not examine her ear, although her complaint of chronic hearing loss in that ear may need to be evaluated by an audiologist. A thorough ear exam is essential to making a diagnosis and placing the referral. As a lodged foreign object or impacted cerumen or certain abnormalities would call for a different course of action first. So that's an example of how you may correct mistakes.
Nehman, one thing that one of our former faculty members, Dr. Burge, recommended is just use the word tips. You've got it right here, but just a couple of tips for the next time you see a patient is kind of a positive approach to that number.
Nice. I like the word tips. Short, it's easy to say, easy to spell. Students should understand that. So here's some tips for using these Microskills. So in terms of getting a commitment and probing for evidence, again, we see very complex patients. So we don't need to get that commitment and probe for evidence on every single thing that's being presented. If you're Dr. Lawler, you may have this strategy and it may work for you. And you may have found out how to get that to work over 40 years. But my suggestion would be, if you're pressed for time, really focus in on one issue per patient. That doesn't mean you're only addressing one issue per patient. That means that you're really focusing in that student's understanding of one main issue there. Certainly more if there's time in teaching one rule per patient. Certainly if the student has done well and is a superstar with the concepts covered and related to caring for that patient, it's maybe kind of tough to teach them a general rule, so you can skip that portion. Keep that in mind. You don't need to dig into these 5 Microskills for every single issue necessarily. In terms of feedback, there's been various studies that have shown that we give feedback, but feedback's not always perceived as such by students. So saying the word feedback, I'm getting ready to give you some feedback. By doing that, it'll be more likely recognized than not. Making feedback a regular part of what we do, creating that positive learning environment, that openness and trust with the students, that's gonna help with certainly transmission of feedback. You've heard of the feedback sandwich, where you start with the positive feedback, you bury that constructive feedback in the middle, then you may say something positive at the end. That's one approach. There's also the open face sandwich, where you tell them something positive and then you give them something to work on. Both are effective strategies. Depends on that, certainly that trust and rapport you've built with the student, but both work. When you correct mistakes or opportunities for improvement or tips, always focus on behavior-specific acts or omissions from the student. All right, so all of that being said, we have 2 more scenarios for you guys to work through. In these scenarios, we need one person to play the role of student, and you'll portray the student as described in the scenario. One person will play the role of teacher. You'll use these Microskills we just discussed to teach as per the scenario. Who can remember the 5 Microskills? What's the first one? Get a commitment. Then?
Probe for supporting evidence.
Probe for supporting evidence. Great. What's the third?
Teach a general rule.
Teach a general rule. How many?
1.
1. Great. What's the fourth?
Reinforce the correct things that were done.
Great. Reinforce what was done right. And the fifth?
Feedback.
Feedback. Tips. Fantastic. Okay, the third person in each breakout group will give feedback to the teacher and the student. So 10 minutes for this activity and we'll rejoin here. Nicole, go ahead and send folks to the breakout rooms.
Okay. If there's anyone still in this part of the meeting, if you're having trouble getting to your breakout room, let me know. Dr. Andry,
Yes.
it's 1:20, so I don't know how much presentation time do you need after you bring them back?
After people return, there's just a few reflection questions regarding the activity
Okay.
and a summary slide. So
Okay.
not much, couple minutes.
Okay, sounds good.
And you know, if you want to cut folks off around maybe the 8-minute mark here, that's probably also fine.
Okay, sounds good. It looks like we just have one room that's still discussing, Dr. Andry, so I don't know if you want me to just close the room. in a minute?
That sounds good.
Okay, I'm gonna hit close and then it should bring them back if they don't come back before then.
Okay.
Okay, you should have everybody back.
All right, great. Well, I know that that was kind of fast paced. Well, I want to be respectful of your time. As we wrap things up, I'd love to hear reflections for what was learned and discussed in the groups. Maybe if we can hear from one teacher, one student, and one observer, that'd be great. So one of the teachers, what did you learn?
Being specific is a little more difficult than I thought in feedback. So it's, for me personally, like very important to be specific and remind myself, be specific.
That's a great point. You know, we run into the same thing as we counsel patients and make recommendations. You have to be very specific, develop those SMART goals, remember. That's a good point. What about the student? What did you learn as a student in the encounter? Well, you certainly learned about, making sure you choose a medication on the formulary and about the other social factors that influence people's health and opportunities. Did you learn anything else?
I think it's just like some students, this isn't their field. So like some of them aren't as motivated to be here, if not very often, just like a few. So I guess we still have to remind ourselves that, they have different interests, and even if this isn't their field, we can still encourage them to see the patients and get the most out of their learning here while they're here, and try not to be as, I guess, biased towards against them just because they're not doing this field.
Fair enough. Everyone has their passions, their interests, the things that make them come alive. But showing those students the value of family medicine and what we do, and they'll be working with us later in some capacity as consultants, and so that they need to know what we have to offer, and to be able to see this side. So I agree with you there. Observers in the scenarios. What's one thing there you took away?
It's not as easy as it looks. And I think when you do this again, it will be helpful to maybe have a script for the student, because it wasn't clear what we were to do. So if you pick a case that has everything under control and there are no differential diagnosis to address or medication problems, then it's harder to practice that skill. So I would say that that's one feedback to you in terms of the exercise. But I think that what I observed was that there was a real effort to try to implement the 5 microskills. And this is a good way to remember those.
Fantastic. I appreciate that feedback. You're right. This won't be the last time we're going through this activity. And like anything, the more you practice it, the better you practice it. Perfect practice makes perfect. So we won't ever be perfect, but hey, we can be better. All right, so I hope you gained a tip that you can enhance your clinical teaching for tomorrow morning if you have a student. And certainly I'm here at your disposal. We want this to be a positive experience for you. If it's a positive experience for you, it's certainly going to most likely be a positive experience for the students. So again, thank you for everything you do. And this is just a brief summary slide here. We talked about all of these things. Yes, what we do is challenging. A 1-minute preceptor model is an effective tool that you can use, and employing strategies to create a positive learning environment and making sure that your expectations are well defined from the start can certainly make your teaching more effective, more efficient, and more enjoyable. So thank you for your time this afternoon, and I look forward to the next time we chat.
Thanks, Dr. Andry, and I am going to email out the evaluation link for everybody so that way everybody can get that and continue on right now with what they've got to get done.
Very good. Thank you, Nicole.
Thank you. Thank you, everybody, for joining. Have a great day.
Take care.